Hi, everyone.
Yeah, good morning.
Hello. I see, is that Gilbert Tang up front?
Yes.
And
Yeah,
Dr.
Gilbert
Kinney and
Tang.
Dr. Dangus and Dr. Kara
And we have
and Dr. Sharma. Where is Dr. Sharma? We need about 5 more doctors in there.
He's on his way here.
All
But then
right,
we
good.
have,
Good morning.
Lirakas,
Did you hear about our panelists? We have a fantastic panelist. We had probably the best 3 lectures I have heard all year on transcatheter aortic valve and on the aortic valve and valvular heart disease. This audience is extremely lucky. And tell us what you got.
and then we have Lirakas, who's our echo doctor.
Oh, Dr. Larakis is
And,
there too, our
and,
interventional
we have
imaging
Venus,
guru.
who's the chief of cardiac anesthesia. He's doing our anesthesia this morning. So if you
All right.
can have the first slide up there, which is a case number 1, 70-year-old male. You see that? Who had
Yes,
presented
yes.
his worsening dyspnea.
I see.
Yeah.
I see.
So
Right now, we
essentially
just
what
see the operators. Let's go to the case. Oh, disclosures, important. Okay, here's the case. Thank you. Go ahead. Who's presenting?
So we can say, so you
Dr. Kinney is presenting. Go ahead.
70-year-old male, known CAD, and who had bypass surgery as well as AVR with a 23 millimeter bovine pericardial valve in 2006. Since then, he has, you see multiple comorbidities, but more important, CKD, as well as prior colon cancer resection, as you see that. Now, due to worsening dyspnea, he was referred for further evaluation here. Good medical therapy. He was already on diuretics and ACE inhibitor, as you see the medications. Then on the cath, you see the left system, we'll show you the angiograms, but left system was essentially non-obstructive LAD, but his OM graft was patent. RCA graft was occluded, and he did have some disease there. Since what happened is when he first presented, we did do the PCI of the right coronary artery. Now today he is here, where we'll show you the echocardiogram for the valve-in-valve aortic valve, which essentially is some degeneration, but a lot of it is AI. Stam, can you show the live echo?
Yeah, if you could show us, well, yeah, it would be good to see the echo and yeah, there we go. Hi, Stam.
You see this? Yes, hi, Dr. Meran. So this is the bioprosthetic aortic valve with X-plane. You can see the long axis and the short axis, and you can see that the leaflets are a little bit thickened, but they are opening up well. Here you can see the aortic regurgitation, and all of us who do these procedures and TIS all the time, we have to take off-axis views because most of the times these jets are very eccentric, as you can see here. And as in this case, you can appreciate that on the short axis view on your right, that the aortic regurgitation is mostly between the no coronary and the right coronary cusps. This true view on the new EPIC CVXI system, just to show that we have this capability, and this is a 3D image that again you can show that the leaflets are opening up well, so there is no problem with stenosis. The most of the problem is regurgitation, and again, for all of us who do these procedures, the most important view to measure AI and to see it better is the deep gastric view, as you can see in this case. And you can appreciate that torrential aortic regurgitation and a very eccentric jet. Pressure half time that we got is 230 milliseconds, which is almost on the severe range. Again, a deep gastric view, very important view to see the aortic regurgitation, and as demonstrated here, very eccentric jet, and this can be missed if you don't look by TE, and that's the difficulty of evaluating aortic regurgitation, valvular and paravalvular.
Yeah,
because,
so
most of the time it's eccentric jet.
Okay, good.
okay, so this
We can
is
shift the next slide.
so you're planning. So we have the so just to make a full. Oh yeah, show us the angiogram. Go ahead with the angiogram.
You can see that left system
Yep.
was a non-obstructive. There's a bypass graft. You can start seeing playing to the
Yeah.
OM, and
Yep.
the right coronary artery, which are significant disease. And after this, the last what you see is the post PCI.
And Dr. Sharma is joining us momentarily. So can we show the hemodynamics though before we, just because it's very interesting, before Dr. Sharma gets ready, we're in the LV now. The pressure is 200/22 and the aortic pressure is 160/40, chronic AI.
Okay.
They don't.
So let's
So-
talk about the CT scan for a minute.
Okay.
Imaging.
So the CT scan,
Well, I
for the access point of view, Gilbert,
So next
Okay.
slide, please. Just so that we can move along. Keep going. Next slide. Next slide. We've seen these slides already. Let's go. Yeah, perfect. So you can see here, this is a Paramount 2700 valve. We can see here a 23 millimeter valve, surgical valve. You can see we did the CT scan. The anatomy looks pretty consistent with what we expect for this surgical valve. Next slide.
Good.
Okay, you can, one before that, I think. Okay, you can see the sinus are very generous. Sinotubular junction is very large. The virtual valve to coronary distance is almost 6 millimeters, so we're not really concerned about coronary obstruction here from the valve in valve. Next slide.
Good.
Okay, so yeah. You can see here, the left main is low. So in these valve in valve cases, we don't really care about the left main height so much as do we have clearance from the valve in surgical valve when the valve is expanded to be able to perfuse the coronary adequately. And we feel that in this case, it should be sufficient. Next slide. Okay. Access is reasonable. You can see here.
And you already
You can see
shown
the arch. We'll show you. We already deployed the Sentinel. So,
in the bovine.
Okay, but before you go there, can we just have a little bit of a discussion so that our team could follow here? We have an amazing panel. Can we have a little bit of a discussion, or do you want to just go ahead and implant and then have a discussion?
No. Yeah. Yeah, we'll just finish this slide. You can have a
Okay.
quick discussion. You can see it with the valve in valve app. This is what we plan to do. This is now the Evolut Pro Plus. We'll do 26 millimeters. And this is kind of our target positioning. Go ahead, Rosanna. You can
Yeah, so
discuss it.
it's great. Thank you for the summary. So 70-year-old guy, and what I want to do is I want to just turn straight over to you, Mike Reardon. Why did this valve fail? What do we think is going on? And obviously there is some, we talk about durability, but there is both AI as well as AS. Is this expected? And how do you, what would be obviously in these kinds of cases, when you have class 3 heart failure, 70-year-old guy, this is a transcatheter approach, right? Mike?
We'd approach this transcatheter also. I mean, because as long as the coronary access is safe, that's the one thing that would make me move away, because there's not much to lose as long as you don't bang the coronaries. And the pericardial valves usually fail with stenosis, and the porcine valves usually fail with regurgitation. So this is a little unusual for a pericardial valve. But of course, they get tears at the commissures, and what happens? You flail, and you get the eccentric jets.
Raj Makar, your approach, how would you choose?
Of course, I think TAVR is very appropriate in this patient. I'm convinced that the AI is severe. So I think you could go ahead and choose either one. I think this is a large enough valve. I think if it was a smaller bioprosthetic valve, I would clearly favor the use of self-expanding valve. But I think either valve is good. You clearly get better hemodynamics if you choose an Evolut valve. I think that is clear. Access to coronary arteries is somewhat better when you're actually using a balloon expandable valve. So I think those are the pros and cons. Here you've got a situation where there is a bypass graft to the circ. So I think that's less of an issue. And I would be very comfortable using either one of these valves.
Samir Kapadia, and also I want to hear about neuroprotection too, since you're
Right.
there.
Now, one important consideration is that he's 70-year-old.
Right.
So you will need a third valve in his lifetime. And so if you are going to select a valve, and then which valve will be better for a valve in valve, and sometimes, with this kind of a coronary sinus height, if you put a self-expanding valve and then put another valve inside, you may create a tube. And although the coronary arteries are not, there is a sinus may not exist anymore. So this is a consideration for the future kind that you may select one versus the other. And again, Sentinel, we use it routinely, and especially this kind of a valve-in-valve, the stroke rate is low. So some people would argue that we don't have data for this because it's as you see, that it is not a stenotic valve. So again, the chance that you will have a stroke is relatively small, but routinely we are using it.
So you guys are hearing the pros and the cons of the self-expanding versus the balloon expandable. I would like to hear how you're choosing, Dr. Sharma, Dr. Kinney, and how you making a decision, Dr. Dangus, any of you.
Yeah. So only question is, we got a little setback here.
Okay.
With the fluoroscopy. Yeah, the room.
The room? That's okay, but fine, but tell us what you, it's okay, you don't have to, just tell us how you would choose if you were, hopefully Flora will come right back on soon.
I mean, clearly, as Samir said, that always in somebody who's 70s age, you have to think about what will happen when after 10 to 12 years of the valve degeneration. That always will be the issue. And in this case, the surgical valve lasted about 12 to 13 years. We expect he gets the same time. And I hope in next 10 years, we might have some other tricks to take care of the leaflet restenosis of the TAVR valve. Whether you do some kind of a cutting balloon or laser or third valve-in-valve, clearly I agree, will be a trouble. In this case, less of a trouble because it's just only the LED supply. Circumflex and RCA has the graft, right?
Yeah. Dr. Colombo, did you want to say something? I see Dr. Colombo.
You know, our institution, we will have difficulties to have this patient accepted for TAVR by the heart team, mainly for the age and the possibility, the need of another procedure. So it's a cultural difference, but I just want to relate that.
We don't have any problem with this patient, the redo patient with a valve-in-valve. We have absolutely, currently, no problem.
I think what is important, not so much whether it's self-expanding or balloon expandable. I think with this patient needs another valve or a third valve at some point in time, it's the supraannular problem. Because if you do supraannular and add another supraannular, then you really have a problem with coronary access. Even though...
So while the discussion ongoing and we will continue to participate, we probably have to go to the next room, the next valve-in-valve case. Yeah, that I think is the right thing to do because this may take another half hour for this to come up.
That's fine. Well, this is a really good discussion, and we'll come back to you to see what, did you want to review some things?
Yeah, I think we just go through this vascular point of view. They have done the vascular access, and this with the all the cinae and with the bovine arch, actually, they still were able to get the Sentinel. We were very skeptical before going in. Yesterday when we evaluated the case, but with masterful of both all our attendings, structural attendings, the fellows and so, able to put the Sentinel. Do you have released the Sentinel? You have the pictures? It's going to come up or no? Sentinel?
Okay.
I see once they deploy the Sentinel, which they saw it, Sentinel is still there. And I think if the issue remains, and maybe we'll take the opinion, more than half hour will be a delay in this case.
Okay. What's your decision for the valve, Dr. Sharma, here, though? Are you going with a...
In this particular case, our valve was the self-expanding.
Self-expanding.
Pro. Yeah.
It's interesting, because probably I would have probably liked to go to the balloon expandable just for the purposes that everybody else was talking about. Eberhard, what about you? Before we go to the next lab, Eberhard, what about you? Would you choose? Well, how would you choose a valve here? There are no data. This is just what you like.
I think, I agree with Raj. You can do it either way. The thing that is, I think, very important that we keep in mind with a 70-year-old that you have to maybe use another valve, and that is a consideration that's extremely important. We didn't think so much about it earlier, but now getting into a little bit younger patients, I think this is a very important discussion that we're leading. And I think, here it's not so much self-expanding versus balloon expandable, it's supraannular versus interannular. Because if you use the Evolut, my question would be, if there's an access issue, why do you use the Pro versus Evolut? I wouldn't necessarily use Pro here in this case, because I think the Evolut would do the same job.
All right. Okay, well, interesting. Dr. Sharma, what's the plan? Should we go to the other room now, or do you want us to have a discussion? How would you like to?
No, I think the valve in valve, it still continues, because to me, I think that is one of the disease which has the best, quite a good outcome compared to even native valve. The better, just like a restenotic, except the coronary obstruction, all events are much lower with the valve in valve. TAVR versus natural TAVR, that has been shown by various studies, but yet we can do it only in the high risk cases. So what everybody feels like low and intermediate risk cases, is still the surgical consideration is right there.
I mean, I think this patient could be a surgical candidate. I think one of the things we discussed, I mean, he's 70 years old. Antonio just told you in his institution, this patient would have to go to surgery. He wouldn't be able to do a TAVR. What about you, in Brazil? And Alexandre?
Rox, I think it's a redo procedure with the patient has underwent
previous bypass.
So I would consider valve in valve, TAVR in this case. My decision is essentially based on the size of the surgical valve. If it's a small one, I would favor a supraannular. And if it's a bigger valve, surgical valve, I would go with S3, with the balloon expandable. And then I watch very carefully the residual gradient. So I'm being more aggressive with cracking the valve if I need to. I don't like to leave with a lot of residual gradient at the end of the procedure.
Interesting.
And this is actually a valve that can be, very well expanded using a high pressure balloon. So.
Yeah, and you don't have much material. It's mainly insufficiencies. You don't have a lot of pannus, a lot of calcium. So I wouldn't expect any remaining gradient here. So talking in this context about cracking is interesting, but I don't think it's really necessary at this point.
All right. Well, yeah, so I mean, I think that's the other thing. What do you do for protection of the coronaries? Raj, in what way are you making a decision, Raj and Samir?
I think that in this case you could get by without protecting the coronaries, because the sinus was actually large and there was quite a bit of a gap. And of course you're part
instead of putting a stent,
sure,
we did a basilica.
Makes sense. Dr. Kinney, are you ready for us?
Ask them to be.
You're magical.
For the last 5 minutes.
Okay,
yes.
Sorry, we just saw you now.
Ready.
All right, present us your second case.
Yes. So you seen the slide for the second case?
Yes, we have it right up.
Good. So this is a 87-year-old female. Same, presented with a worsening dyspnea for the last few months. So she actually had a TAVR, had two BAVs and a TAVR in 2012 with a 23 millimeter SAPIEN valve. So with regards to CAD, if you see, she does have CAD with in 2007. She had a PCI of the RCA as well as RAMUS and other risk factors. You can see what she is on. And for suspected leaflet thrombosis, she has been on Coumadin. So you see the medication for diabetes, for hypertension, and Coumadin. So actually one thing that there is, she does have a pacemaker, dual chamber pacemaker, which she developed a layer, complete heart block or for slow AFib in between. So she had a cath which showed non-obstructive coronaries with patent stent, but a significant gradient across the 23 Edwards SAPIEN. So we can show the echo now. Stamp?
Yes. As you can see, this is the prosthetic valve that is very degenerative, very thickened leaflet, calcified. The right coronary cusp doesn't move. This is a short axis. Again, the same thing, thickened, calcified leaflets, immobile right cusp and partially immobile left cusp. This, as opposed to the previous case that was mostly AI, this is mostly severe restenosis of the valve, again explained. short axis and long axis together. And this is, you can appreciate the turbulent flow through the valve because of the stenosis. And also on your right in the short axis, you can see the flow through the left main and the LAD. This is a gastric view, the only view that you can take the gradients with a TE. You can appreciate again the very thick and calcified leaflets immobile with decreased excursion. This is a color through minimal aortic regurgitation, and these are the gradients that we got today. Peak gradient of 95, mean gradient of 55, velocity of 4.9. So severe degenerative aortic stenosis of this bioprosthetic valve.
TAVR valve.
TAVR. So this is a SAPIEN that was placed in 2012. Is that correct?
Yes. Yep,
So
that's
how?
right.
I mean, honestly, this is the first I've seen. I'm just, you know, from even is this the first in our institution, Dr. Sharma?
No, we have actually seen a few. I mean, again, there is small number, about 2% degeneration at 5 years. And so this case actually, initially we thought it was more of a thrombus. Patient has gone through last 2 years, 2-3 TEs, 6 transthoracic echoes, and continues to have an increasing gradient. So with that, and now more symptomatic, and the gradient has become, as you can see with the hemodynamic, if they can show very high
the
gradient.
hemodynamics now?
Yeah.
Wow.
See that in the right corner is a more 50 plus millimeter gradient. And now this is, and patient clearly had a re-evaluated back in 2012. It was not a candidate for, she was not, she was extreme risk surgical. Even now, again, of course, we continued the same way. And 7 years down the road with the age of 87, no surgical option. The question comes is what to do. It could be a little thrombus on her, on the valve. And the issue was we could not have used the Sentinel in this particular case because right radial is absent.
She has been fully anticoagulated
So she's
before.
right now fully anticoagulated, Dr.
300,
Sharma?
300 plus ACT.
Yeah, ACT is 300.
And she received oral anticoagulation for a period of time to see if this could resolve, that this is not a
initially,
clot?
Yeah, she was on rivaroxaban one time. Then for last 18 months, we put her on warfarin with the INR between 3 to 3.5. And that actually, despite that, gradient continued to increase. The initial thought process was combination of both valve degeneration, TAVR valve degeneration, as well as the thrombus. But it seems to be, with the subsequent echoes, with STEM agrees, and that was the last echo done a few months ago, that it seems to be 95% degeneration, 10% maybe a thrombus, but 95% degeneration of the our TAVR valve.
So Raj, how would your core lab read that echo? Is that a I know you need the 3D CT to really distinguish this, but how are you evaluating this? Is this thrombosis?
We did that. I mean, we did the 3D CT also, yes.
You know what? I mean, on 4D CT, you want to look at the appearance of halt, hypoattenuated leaflet thickening, and of course, reduced leaflet motion. But I think at times you have to do a trial, and at times you also have to take into account that this is 7 years out. Late thrombosis can occur, but I think once again, this is the time when you're thinking more about valve degeneration.
Samir?
And also the calcium, you see the shadowing from the leaflet.
Yeah.
So if there is calcium on the leaflet, that is for a prosthetic valve. That is, it's a sign of death. So I think you can
Eberhard,
definitely.
Grube, any comments?
I
Dr.
agree
Grube?
with both of them. I think 7 years, it's very possible that this is just degeneration of the previously implanted valve. I don't think it's a thrombus issue.
Okay, so tell us how, do you want to go through the CTs now?
Good. Yeah, we actually have...
Gilbert?
Yeah. So you can see, back one slide, please.
Okay.
So you can see this is the inflow of the SAPIEN valve that was implanted previously. You can see it's slightly underexpanded, but still we're pretty close to 23 millimeters. Next slide. Okay, and then you can see here the sinus valve is not that generous. It's like around 25 or so. And you can see the inflow mid-body and outflow also show the valve is pretty close to nominal, around 23 millimeters, and there was no sign of thrombus or halt at least on CT, but there is some calcification consistent with the echo. Next slide.
And Roxana, you are right. This is one of the case. We have seen some cases, thrombus and restricted leaflet motion requiring a tower in a institution. The true leaflet degeneration, calcific, is the first one. Yes,
Yeah, I
that's
don't think I've
absolutely
ever
correct.
seen this before.
Yeah.
How often do you see this, Samir? You've been
So
doing this?
we have now 6 cases, and I'm impressed by this because they are all very similar. So when you
So maybe
have
we have
this,
to
so
combine
what
our
are
data.
what are the few important things that are very common is that the sinuses are effaced. So there is a higher risk, I think, when the sinuses are effaced, you cannot have a drainage of the leaflets, and that may lead to early degeneration. The valve implantation is typically lower than what you like to see, in the sense that initially we used to put this valve 50-50,
Yeah.
and these low implanted valves, and we published it to say that more than 8 millimeter depth and effaced sinuses were very common in all our cases, which came back with degeneration within 6 or 7 years.
Wow. Okay, Dr. Kinney, tell us.
Yes.
Take us
So
through.
let me just finish the CT scan. I think there.
Sure.
One slide, please, Dr. Sharma. Okay. I think there's one important teaching point. We'll show this shortly on fluoro and on angio. You can see the STJ is very small and calcified, around 21, and the left main rise literally right above the old SAPIEN valve. So in terms of valve selection and valve deployment strategy and left main protection, we'll talk about that in a moment. Next slide. But those are some things they would consider. Access is not a problem of this patient. Next slide. You can see the anatomy of the arch, but then, the radial access was an issue, so we did not use Sentinel.
And the question is very
right.
important. Here we have now the SAPIEN valve degeneration. This is a SAPIEN. And now question is, do you use another SAPIEN? Or you use a small core, the Evolut, but the problem with the Evolut will be the size.
Yeah,
which we are
so
going
this
to
is the
use
issue here. You have already a small size, you have a failed balloon expandable valve. What are the choices? And, Alex, how do you approach something like this?
What is our panel
Yeah,
use?
the
Will you
panel.
use
We're
this
going to go
particular
through one by one, starting with Alex.
In the old times of DES, we always choose a different DES just for revenge.
Yeah.
I think that in this case, I think you could do both. Perhaps now I would try a supraannular according to coronary protection. You see if this is feasible.
Dr. Grube, you think the sizing is good enough for a supraannular
I think the previous
self-expanding?
case, in the previous case, it would make a difference. Here, I would use a supraannular valve with a 23 SAPIEN.
Okay.
Somehow we cannot hear Grube, Eberhard, maybe his mic.
Why can't you hear Eberhard? Very important to hear Eberhard.
I know, of course, we need to learn from him. So everybody else I can hear, but we cannot hear Eberhard somehow. The mic,
Eberhard,
we need
use
to
this
hear the mic
other
there.
use this other mic, please. You got to keep them. Yeah. Go ahead. Keep.
Okay.
So what would you do, Eberhard, so that they could hear again?
You mean
Supraannular.
on the present case, or
This case.
I would not use the SAPIEN because
Again.
the 23 SAPIEN are already. You add another SAPIEN intraannular. I think the opening area. You can argue the age. The patient will not run marathon, but if we go for an effective orifice area, I think it is better in
Somebody
this
has to
particular
hold the
case to
guy.
use a supraannular.
Hold the guy. otherwise
Okay. Everybody else? Any other new thoughts?
I would be very worried about. I'm a big supraannular fan, but I'd have to look at the CT. I'm worried about the stovepipe sinuses, and the problem with supraannular is that you sometimes don't obstruct right then and there, but the next day they occlude because there's low flow,
Yeah,
and
the
protecting the
following
coronaries
day.
doesn't help.
I
So-
worry about the coronaries here.
I agree, and I would use the SAPIEN. I think the SAPIEN is a good valve for this particular purpose because otherwise the coronaries will
So
get
you see, you could just
compromised.
flip a coin, use whichever one. We have half and half in either one. So, Dr. Kinney, what did you
But
choose?
if you look at it, the left main is just above the
angiogram
frame.
Here for a moment, the one that was safe.
Yeah, great. Show us.
Can we
Oh,
show
okay.
the-
We
no,
see
not
what.
the live, but the early angiogram.
Okay, we have to show.
We have to show. Okay.
Go previous 1 second quickly before we.
Perfect. I want
go
to
the
show
valve.
this. This is a
Offload.
We are at the wrong time.
Yeah, no, but just one.
Yeah, just show that one. Show this. So on live fluoro, please.
We don't
On
see the
video.
live fluoro. Okay, here we
So
go.
see this? So this is a very important. You see the white line sign just below the left main, above the SAPIEN valve there on the left side, the right side of the screen. Do people appreciate that?
Yeah.
So that's our concern. That white line sign is the native leaflet,
Okay,
and so if we use a balloon expandable here, even what the panel suggests that we're concerned about coronary obstruction, and that's why we have a wire in the left main.
Okay.
The guide.
Okay, let me just,
Yeah,
that's fine.
not looking good. Okay.
And then we have to deploy the valve just where the white line sign was, so that we
That's
can
good.
just
Okay?
Take a Sentinel out.
be able
You
to.
have to hold it.
Yeah, holding. Yeah, go. Sentinel at speed.
Okay, 180. Inject.
Good.
Okay, stop.
Yeah.
Stop pacing.
Okay.
I think we are good, right?
Everyone agree?
Want to go?
Stand
Is
by,
it a
what
little
everybody
bit, I
thinks
am a
there.
little bit worried about, what does everyone think about the positioning?
20.
Yeah, wait a little bit.
Good? I feel like it's a little too
So we're
high,
going to walk down.
Go slow. Go slow.
but,
Little high, we went in.
Go slow. Go slow.
We went in by millimeter.
okay, now that looks a little
180.
bit better. That looks a little bit better because I could see where the coronary is right there.
Okay, going
And it
up.
just looks a little bit close to the coronary. So,
Yeah, but we have the protection there.
Yeah, see.
yeah, we see that.
Okay, good.
Go, go.
So I'm fully gone. It's 8.
Yeah, and you're right. The biggest concern in this particular case
Stop
was
pacing.
the coronary issue, and that is we thought that if we put the Evolut in this valve, coronary will be even tougher.
So you
And I
just
just
have
worry
a,
about, like, you see the distance, there's like, in between the old and the new valve, you see that, it's just not fully well expanded, even though with your good work.
See the white line sign?
That's okay. Looks good.
Do
So
people appreciate the white line
good.
sign?
Yeah.
Right above where the native leaflet is.
Can you show the EKG?
Hey, Gilbert, I have a question for you, Gilbert. Are you going to pull the wire out now that looks good, or are you worried about the wire pinning the leaflet down?
Look at the
We're
white.
going to take a couple of views.
Yeah, look at that white
Before we
leaflet. We're
know,
going to
we
do
are going to
a
take the
number
wire
of
out.
different coronary views to make sure,
It's
because
right
you can see
here.
that white leaflet is riding very close to the ostium.
No, we see it. We see it very close to the ostium, yeah.
1 second.
That's exactly what our concern was. And you can't really see this on CT. You have to do
Yeah.
an angio.
So intravascular ultrasound can be helpful to see the leaflet,
The leaflet.
that how far it comes in the.
10.
What does the panel think? Would you guys do anything here?
Let's see. We'll take a picture first. Yeah.
I mean,
I don't have a
I
diagnosis.
feel
Bring
like you
your
need
guide
to,
back a little
you
bit
need to
and then inject.
post-dilate this.
So,
I would take the guide back and,
yeah, pull the guide back and take a picture so yes.
No, wait.
Yeah.
We'll see. Rise time is a problem. 0 rise, okay?
0, no?
Ready?
Okay.
That's okay, I have it. Go. Yeah.
I think it's okay.
I think it's gonna
looks
be
good.
okay,
It looks
yeah.
fine. There's a little bit of a sign here.
Okay,
So
now,
are you
is
worried,
that going to
will
say something?
post-dilation though, could the post-dilation impinge on that? That's the other, the question right here is, do you leave this or do you post-dilate with a risk of, could there be a risk to the coronary ostium if you go a little bit more aggressive opening this? But
But see the gradient before. Maybe you don't need post
the
dilatation.
gradient is 10, they just told us.
No.
Leave it.
No.
We are
don't
not
have
checked yet.
gradient.
Yeah.
Oh, he's
Oh.
right.
Yeah, echo
Go,
gradient.
go.
Yeah, you're
Echo.
right. It's an echo gradient.
Okay, so this view, I think it's clear. There's no obstruction now.
No, that
No, I
looks
think-
good.
View? Yeah, in the previous view. So the question was, will you take the wire out? I think you need to have the wire across until you're 100% sure you're...
Stan, what do you
That's the
think?
hemodynamics now. Let's take it out.
Also
Good
by-
point. No.
My echo is what?
By echo, there is a good flow in the left main.
Okay.
Wow.
Oh, okay.
Not so there is no
Echo
paravalvular.
showing the good flow in the left main.
There is no paravalvular leak.
Now, what if you need to post, you're saying?
And
Just do hemodynamics.
So I don't think you need to post dilate, Roxanne, because the low
Well,
gradient.
let's see what the gradient is now hemodynamically, but I just feel like, we heard this guy is gonna need a third valve, right? Or, oh no,
Can you
this
show
is,
echo,
he's
please?
87.
Stan, want to
This
show
is the
the echo?
87-year-old, okay.
But
Just wanna make sure we get a good result.
She will not be the one, yeah. She won't be for the third valve, right? Unless...
Unless you have
but
some
she may be
problem
overall-
here. There's a
Yeah,
little bit of
overall, I mean,
paravalvular leak.
Overall, she has so many other conditions going on for her. and she's quite frail. That's one. She walks very slowly.
So you can see the echo, that's what Stam is pointing out. The left main flow is excellent according to him.
Very brisk flow.
Brisk
the left
flow,
main.
good. Thank you, Stam.
No para leak.
Maybe we can wire the left main using
I can
echo.
tell you, see what the day has come to, that we are deciding left main flow on echo, not on an angiogram. There is a lot of improvement in echocardiography.
Soon we'll be wiring the left main using echo.
See, this TAVI was forgiving because the frame of the SAPIEN, old SAPIEN valve was short.
Show the hemos.
Yeah.
But you can see this being a problem as we move even to a SAPIEN 3 in the future. I mean,
That's right.
of course, it's a problem with the self-expanding valve.
Oh, no, this looks good
This
now.
was,
No gradient.
So
Less than, well, I can tell you, echo said less than 10. It's only 8. Even less, 5.
That's good.
and
Excellent.
this was the Sapien Ultra that we used.
Okay. Well, this looks good. I mean, it really is tremendous in this 87-year-old to have this technology, to be able to do this. But I'm baffled. What I'm really interested in, what are you going to give her when she has non-valvular AF anyway, right? Isn't that correct? She's in atrial fibrillation?
She had been on NOAC before, and
Yeah.
then we started for last 1 year on warfarin.
Okay.
I think we are done with this particular case, and you want to start your lecture, will be fine. But yeah, she will. Now question is, should I continue warfarin or I go back to her NOAC, which she was taking for last 10 years?
Yeah, well, she had the thrombosis and the valve thickening on a novel oral anticoagulant, isn't that right? I mean, I think I
That is
would
correct,
I
but-
would go with the benefit of the doubt of what you did with Coumadin, although she's 87 and she could have intracranial hemorrhage. And then the other question is, do you feel like she needs clopidogrel on top of this or no? Because you said you give everyone aspirin clopidogrel for 3 months at least.
In this particular case, she will need one of them. Reason, she also had a multiple stents in the past of the right coronary artery and one of the time ramus. So she had a PCI also. So we haven't done PCI in last 10 years, but this is my patient for last 20 years. So she had been now maintained NOAC plus aspirin or warfarin plus aspirin, but because clopidogrel had been off for a long time. So question to me, I think that now since we are not putting a stent, I probably will continue aspirin. Only decision is she was not happy for last 1 year. When we switched to warfarin, should we go back to her rivaroxaban and not knowing that warfarin we changed to thinking it will delay the gradient progression and that removal of that thrombus. It probably did a little bit on the thrombus, but gradient continued to increase.
Samir?
Anticoagulation strategy. The question I had, some technical question, can I ask?
Yes, of course.
So one question is that with the permanent pacemaker, how many of you put a temporary wire? You just don't use the permanent pacemaker, because we have been using just permanent pacemaker to pace people and not put a temporary wire. And the second is
We routinely use the wire in the LV to pace. We don't use any temporary pacemaker.
No, but if you have a permanent one, you don't even need that, right? You just use a permanent pacemaker.
Yeah, you need to call the device rep to be in the room, and we have tried it twice, but we were not happy with that system, so we just keep going. This is completely under our control, so we just do it.
And then take it out in the end. Yeah.
Okay, ready?
What do you think, Raj? How do you guys do it?
So we've started using the LV wire to pace very frequently now, and we always do that when we have a permanent pacemaker. So that's our approach.
We do the same.
Antonio? Yeah.
We use the
do
LV
same?
wire. You have to cover the wire with the catheter, with a balloon, but it's very effective. But you have to cover the wire. You cannot just leave the bare wire.
Well, this
I
looks
put in
really
a I put in
good.
a jugular pacer in everybody because I've got
So
fellows
let me
that want to
just
do this.
tell you, we're getting close to the 10:30 hour.
We are done with the 1.5 case.
Yeah.
Because the other half case was not done. So we did only 1.5 case today. But that's okay. Maybe we'll, once the...
Well, you'll show us what you did in that room when we come back to you. And you'll take us, please, please fluoro everything so we could see step by step.
And you go with your lectures and so.
Yeah. So I would like to kind of thank you guys. This is a beautiful case, and we'll see the rest of the half of the other case soon. Thank you guys. Thank you.
Okay, very good. Thank you.